So we can start with the first slide, or where's the computer?
Oh, I have it here.
Yeah, you can start. I can drive.
Okay.
I can hold it there, so I can just go back, so we can look at the algorithm, because we're gonna be going back and forth. I want you guys to be very familiar with the algorithm. And
kind of got a lot of wires, but.
thank you. What is this thing here? Oh, it's a pen.
Oh, yeah.
Oh, this is like a tablet.
Yeah.
You guys see patients with this?
Yeah.
Oh, that's cool. Oh, that's great. Okay. Very good. Very good. So, you know, oh, did I call someone? Is the phone ringing?
I think it's just Ramirez.
Okay. Very good. So, essentially, anemia is part of your job as a primary care provider, and it's also heavily tested on your boards. That's the reason why I think I'm interested in teaching you guys the 3 approach, like the medical student, the attending, and the response to the therapy. But if you look at the textbooks, we have a kinetic classification, which is basically intended to stimulate students to think about the physiopathology behind, like either because this is a decreased production or increased destruction. But there is also a morphological classification. When I was in medical school, I think that's most of the teaching came from the morphological classification. And I think it's good that you understand both, because there's going to be a lot of overlap in these 2 classifications, but it's intended on the MCV. You guys know, we all know what MCV is. It's a medium corpuscular volume. It's pretty much is the average size of the erythrocytes. And based on that conclusion, we can label the anemia as either microcytic, normocytic, or macrocytic. But there is also, like, on the kinetic classification, we also have increased destruction, and there's an immunological classification which is based on the Coombs test. You can either have a hemolytic anemia, either immune-mediated or non-immune-mediated. Like, we're going to be covering some clinical cases on this talk. But the medical student approach, I want you guys to always look at the reticulocyte. On your boards, questions are pretty straightforward. They're not going to be tricking you. They're not going to be giving you a multifactorial anemia. They're just going to give you a case that you guys need to. Ramir is supposed to send you guys the handout, so you know you're going to have the PowerPoint if it makes it easier for you. But I told him to send it to you. But anyway, so if either you look at the reticulocyte count, and then you can conclude if the anemia is from decreased production, either because you have some sort of like bone marrow problem. And the bone marrow problem can be from lack of some sort of nutrient. We're going to talk about that. Or it can also be related to some immunosuppression, or I'm sorry, some bone marrow suppression related to a medication. Or it can also be related to infiltrative diseases of the bone marrow. And like those are probably the more challenging types of anemia to treat, and that's usually under the care of the hematologist. But your job in primary care is basically is never to miss a hemolytic anemia, especially if you're going to be working more in the inpatient setting. When you're admitting patients, one of your jobs is to do a quick assessment of the patient needs, and not to miss hemolytic anemias, because the management is very different than the typical anemia management. And also, if it's elevated, basically it's pointing more towards increased destruction or acute blood loss. If you have a patient with a chronic GI bleed, they're expected, if they have enough iron, enough folate, enough vitamin B12, they're expected to have a good reticulocyte count. Okay? So if there is decreased production, you can narrow down the causes in terms of the MCV. Like, that's why I have a slide that I took from UpToDate, specifically showing the morphologic approach. So it's the easier way, the quick and dirty way to remember is if the MCV is low, then you do the iron studies. If the iron studies are low, then you know that you're dealing with iron deficiency anemia. Do you guys know what the definition of iron deficiency is? You guys remember, like, what is the cutoff? You guys remember for ferritin, or for for percentage of transferrin saturation, or the iron level? So remember, ferritin is an inflammation marker. So ferritin can be false positive or falsely elevated in many clinical settings, especially in anemia of chronic disease. You can have a very elevated ferritin. So we pay more attention to the iron level. So typically, the iron should be greater than 30. And the percentage of transferrin saturation, or I'm sorry, yeah, the percentage, the ferritin, if we were going to talk about ferritin, if it's less than 100, that's consistent with iron deficiency. If the percentage on transferrin saturation is less than 30, that's also consistent with iron deficiency. So if you remember those two, you're going to be good. So if the MCV is normal, then you look at the creatinine, and the reason is, you guys know why we look at the creatinine? Erythropoietin deficiency associated with chronic kidney disease. I'm going to cover some of that. But, you know, like in your boards, if they give you a normocytic anemia with an elevated creatinine, you already know that you're dealing with anemia of chronic kidney disease. And do you measure erythropoietin level in those patients? There's no need for doing that. So, and they're going to try to trick you to answer that. You don't have to, because you have to, it's absolutely appropriate to assume that the anemia is related to chronic kidney disease. And the reason why we don't check is because there is a lot of variability between the levels, and it's not really helpful, clinically helpful. What we do is just, we make sure that the iron levels are replete, and we give erythropoietin stimulating agents to our patients. And you look at the TSH, because hypothyroidism can be associated with with a normocytic anemia. And if everything is fine, then that's when you consider like doing a bone marrow examination. Wouldn't do it in everyone, obviously. And in primary care, you're not going to be the one doing that. You need to refer to the hematologist. Who does the bone marrow aspirate? You guys know who does it? Which specialty?
Oncology?
The hematologists themselves. So that's part of the training. You know, sometimes you can refer to interventional radiology, but the hematologist is a bedside procedure. It's quite painful or quite uncomfortable. They can do it in different places. The more commonly targeted is probably the iliac spines, but they can also do a pre-sternal bone aspirate. You can imagine like how uncomfortable can that be. Okay, and then lastly, you look at the MCV. If it's high, you check for the folate and the vitamin B12 level. So, and the third thing you do is you look at the reticulocyte count. If it's increased, then you check a direct CUM test, because we're going to be dealing with the immunologic category. Okay? So first you look at the reticulocyte, then if there is decreased production, then you look at the MCV. Okay? And we already covered that. And then the third thing, if the reticulocyte count is increased, then you look for the CUMs. Easy, right? Easy approach. I'm going to show you. And then lastly, you look for the peripheral blood smear to confirm or to support the diagnosis. On your boards, they're likely to show you peripheral smear samples. I have some in the questions that I included for your review. Okay. So this is the slide that I want you to pay attention. I want you to memorize it. It's a little busy, but we can go back every time we have a case. But on your left, you're going to have like the MCV less than 80. Again, you check for the iron studies. On the far left, if the iron is low, if the TIBC is elevated, and the ferritin is low, then you know you're dealing with iron deficiency anemia. If the iron studies show that the TIBC is normal or low, but you have a normal or high ferritin, that's when you have like anemia of chronic disease, which is probably one of the most common causes of anemia. Either you have infection, you have inflammation, or you have malignancy. This is probably, aside from iron deficiency, is probably the second most common cause of anemia. It's the anemia of chronic disease. And lastly, when you look at the iron studies, and the iron studies are normal or high, then you send a hemoglobin electrophoresis, because that's when you may be dealing either with sideroblastosis. You need to do like a bone marrow just to determine the cause. Or you can be dealing with some of the thalassemias, and that's why you send the hemoglobin electrophoresis to be able to narrow down the diagnosis. So The bigger category is when the MCV is normal, which is most of the patients. So that's when you have to pay attention to the peripheral smear. And then that's when you have to rule out the presence of hemolysis. Which labs do you order for hemolysis, by the way? Let's say you're the hospitalist, you're the resident, or you're the intern at meeting, and you want to rule out hemolysis. What are the labs that you send? You guys remember? The first, reticulocytes, obviously. Yeah. And then what else? LDH? Haptoglobin is expected to be low. Actually, it's grabbing all the available haptoglobin.
Indirect deletion.
And if you have a hemolytic anemia, haptoglobin is usually low. What else?
Billy?
Yeah, Billy. Yeah. Indirect bilirubinemia. What else?
This is just all the cells lysing, so. If you want a CMP, would cause elevated potassium.
You can have hyperkalemia. Yeah, you can have hyperkalemia associated with hemolytic anemia. That's actually one of the differentials for hemolytic anemia. I'm sorry, for hyperkalemia. But that's pretty much it. You know, you can do a D-dimer. D-dimer is usually pretty high in the setting of hemolytic anemias. But again, if you suspect hemolytic anemia, if you're admitting a patient, those are the labs that we normally do. Those labs can be misleading, especially in the setting of kidney disease. You can have like a false positive D-dimer. Or in the setting of let's say ongoing malignancy, the LDH can be quite elevated without necessarily being explained by hemolytic anemia. But that's generally speaking like the initial workup for hemolytic anemia. And then you have to rule out the presence of blood loss. How do you do that if you're admitting a patient? What do you do? What kind of test do you do?
I learned not to do fecal blood tests. I graduated up for that one. They're like, everyone has it, so like, I don't know what to do.
No, but actually we do it routinely. We have to.
They told me not to do it. It's like, everyone's gonna have it. I was like, oh.
No.
I thought that was the first step.
No, we always have to do it. You know, your job as an admitting internist is to rule out. In fact, let's say that you're in the urgent care and you're presenting a patient to the ER docs.
Yeah.
They get very upset if you haven't done your rectal exam.
Maybe like in the inpatient though?
Inpatient, yeah.
Okay.
Yeah, in the outpatient, if you have a positive fecal occult blood, then that's basically, it's indicated that you pursue an additional workup. Either you do a sigmoidoscopy or a colonoscopy. You know, that's more like intended for colorectal cancer screening. In the inpatient setting, if you're admitting someone with anemia, the new assays are pretty sensitive and pretty specific. So it's common practice that we do a digital rectal exam. We smear, whatever you have in your finger, you smear in a little. I'm sure Dr. Ben-Zur has them here, and then just put a little developer, and then you can tell whether or not somebody has the presence of a GI bleed. Okay, bone marrow suppression. So if you have a normocytic anemia and there is like a suppressed bone marrow response, then you expect to see low reticulocytes, right? So low reticulocytes, it's a very important part of your anemia management. On your boards, they're always going to give you, most of the times I remember that I got my reticulocyte count. So that's how you can break it down. And then the renal insufficiency, they're going to give you elevated creatinine. I want to pause there because you're going to get questions about multiple myeloma on your boards, guaranteed. So they're going to give you several scenarios. I'm going to describe it so you're familiar. Typically they give you like an older person, not that myeloma cannot happen in a younger person, but typically it's an older person's disease. So I can give you an older person. That person can present like with some sort of like diffuse pains, bone pain. They can show you an X-ray with lytic lesions. You can see like the skull lytic lesions. They're gonna give you, the patient is gonna have a normocytic anemia. The patient is going to have a low reticulocyte count. The patient is going to have elevated creatinine because myeloma is very toxic to the kidneys. Last time I reviewed it, like there's 6 different ways that multiple myeloma can injure the kidneys. It can cause interstitial nephritis. It can cause, light chain nephropathy. It can cause myeloma kidney. It can cause hypercalcemia-induced kidney damage. So there's many different mechanistic ways of injuring the kidney. So invariably on your boards, they're going to give you a person with renal insufficiency. and they're gonna give you what we call a mismatch in the proteinuria. I don't know if I talked to you guys about that, but if you look at the UA and if you do a dipstick, all you're looking for is albuminuria on the dipstick. But when you send a sample for quantification, either with a spot urine for protein creatinine or with a 24-hour urine collection, that's when you're able to pick up non-albumin proteins. So they're going to give you a UA with no proteinuria on the dipstick, and they're going to tell you the 24-hour urine collection revealed 3,000 milligrams of protein. That mismatch it's multiple myeloma until proven otherwise, and you're going to get that on your board. So remember to look for that mismatch. And the reason is that the UA, they don't run the sulfoxylic acid assay. That's the one that picks up non-albumin proteins. So that's key on your boards. Okay. All right. So and then if the MCV is high, then typically you send a folate and vitamin B12. Then you can think about like liver disease, because this is one of the common causes. If it's an old person, then you're pretty suspicious that this may be related to myelodysplastic syndrome. I'll talk about that later. And there's another big category, which is medication induced. Have you guys ever taken care of a patient with HIV? Have you guys seen labs for patients with HIV? So take a look if they're taking any of the protease, any of the ACT belongs to what family? What's the name of the family? It's not the protease inhibitor, it's the other group of medication. No. It's the first ones that came out in the market. I can't remember what the name of. It'll come to me. But anyway, patients taking that or taking anti-TB medicines, they always have macrocytosis. And one of my ID attendants used to tell me if they're not taking the medications, if they're not macrocytic, they're not taking the medications, period. So that's another way of monitoring compliance with medications. All right, and then we have like other things like hypogonadism, some of the drugs that I'm going to cover at the end, and liver disease.
I have a question about that. So where does sickle cell, I might be missing it, but where does that fit in? Is that normocytic?
Sickle cell can be normocytic. Sometimes you can have a combination because you can become like iron deficient as well. So it can be microcytic. And so in clinical practice, these clinical syndromes, there's an overlap. On your board, it's pretty clear cut. It's hemolytic anemias are usually, they're usually done in the MCV, in the normal MCV, the normocytic anemia MCV. Okay. Very good. So this is another algorithm. So you have like the patient has anemia and has a decreased reticulocyte count. So you look at the MCV. So if it's macrocytic, then you already know it's either iron deficient or thalassemia, right? Or sideroblastic anemia. Sideroblastic anemia can be caused by different things. Some like copper deficiency. Patients are using zinc. I don't know in which clinical scenario you would have used zinc, but it's on your boards. Medications, systemic diseases. We have. If it's normocytic, you think about systemic diseases, either renal versus liver versus endocrine, versus anemia of inflammation. But it can also be diseases in the bone marrow, either myelodysplastic anemia, myelodysplastic syndrome, solid tumor, myeloma, and aplastic anemia. And then macrocytic, usually vitamin related, B12, folate. And if it's non-vitamin related, like I told you, myelodysplastic syndrome, alcohol, liver disease, or hypothyroidism. Okay? All right. They may give you this picture on your boards, so you already know that if it's similar to the one on the left, you have to suspect hemolytic anemia. So the patient basically presents with anemia and the patient has an increased reticulocyte count. Then that's when you send the Coombs test. If the Coombs test is negative, then you think about like some sort of like extrinsic red cell defect. They may give you a patient with a prosthetic heart valve, or they may give you a patient with some sort of like artificial procedure, or they may be hemolyzing from either a toxin. You know, which toxins are associated with hemolysis? Do you guys remember? Do you guys remember the Shiga toxin?
Oh yeah.
So they may give you a case of a person who didn't eat, or I'm sorry, who ate uncooked meat, like a hamburger, and they may, you know, that person may present with like diarrhea, renal failure, and hemolytic anemia. So some of the toxins can cause the hemolysis. Some of the, like the diphtheria toxin, I think, is also associated with hemolytic anemia. Yeah, but it can be like external, it can be an environmental, but it can also be an infectious insult. But if the patient has a negative Coombs, then you can think about, like, is this an intrinsic red blood cell defect either in the membrane and the cytoplasm or the hemoglobin structure? They're like rare diseases that are associated. But if it's positive, then there's two types of hemolytic anemia. I think the warm and the cold. I'm not very familiar how you treat them. I know that these patients immediately you need to give them steroids, and sometimes they need to give what other procedure? When you have like a severe, like say you have a patient with TTP. I got it wrong on my board, so I still remember that. You guys, have you ever seen a patient with TTP?
Yeah, you don't give them. You have to give them IVIG, but you can't give them.
But what else do you give them? Plasmapheresis, that's the correct answer. So we're going to ask you, what is the next step in management? I wrote steroids. You give them steroids, but that's not the most important step in management. It's actually plasma exchange. And these patients from TTP, they present with the pentad. You guys remember what are the 5 clinical manifestations? The pentad symptoms? Fever, what else?
Renal involvement.
Renal involvement, what else?
CNS.
Altered mental status or CNS. What else? Hemolytic anemia. Yeah, MAHA.
And what's the last one? I forget.
TTP.
You get TTP because TTP-HUS.
Thrombocytopenia.
Oh, okay. So thrombocytopenia. Okay.
So they have like a, yeah. So those patients, if you get it on their boards, plasma exchange. Okay.
So you can't give steroids because you can kill them, right? If you give steroids.
No, you give steroids, but they want to stress the importance of like.
Oh, you don't replete platelets.
You don't replete platelets, yeah. Yeah. Okay. It's the increased consumption. You need to just remove that AMS 13 defective molecule. You need to plasmapherese these patients. Okay, so this is how we do the attending approach. You're gonna laugh when you're practicing, but you need to know your fundamentals, and then you go to the real world. So if you're in the outpatient setting, you do 3 YX stools. If you're in the inpatient setting, you do just 1. If the MCV is low, then you give him iron. If the MCV is high, then you check a folate or a vitamin B12 level. If the folate level returns like questionable, then you start giving them folic acid. If the B12 level returns low or indeterminate, then you start giving IM vitamin B12. You can do PO or IM, but if you truly have like a pernicious anemia, you should be giving like IM vitamin B12.
You guys never get MMA, huh?
We never get what?
Like that methylmalonic acid. Like I tried Orient once, they're like, oh, we don't do it.
Well, if you really want to confirm vitamin B12 anemia, vitamin B12 deficiency, you have to send either that or a homocysteine level.
Oh, okay.
See, if your homocysteine level is low, I actually have a little slide here. Let me see.
I thought it was high in both.
High. Sorry, high. If it's high in both, then you confirm that you're dealing with
But is that medical
like a true,
or is that pending?
In the real world, I mean, it's not common to see vitamin B12. I've seen it probably twice.
Oh, okay.
And you start repleting them, they get better, and then you don't. But the textbook, the medical student way of doing it, you have to send it to confirm that. Okay. Okay. So, and this is the pharmacologist approach to the anemia. So again, like I call it nutrient responsive or erythropoietin responsive. So if the nutrient responsive, either you're giving them iron and they get better. How many formulations of iron do you guys remember, or have you guys familiar with? What forms of iron do you guys know?
Like ferrous sulfate?
There is ferrous sulfate. What's the most common side effect? Actually, GI upset, yeah. GI constipation. black stools. Some patients are completely intolerant to it. So there's also like ferrous, instead of ferrous sulfate, there is ferrous gluconate. But sometimes the patients are totally intolerant to iron. And there's really nothing you can do other than send them for an IV infusion. And what kind of irons do you guys remember? IV iron. So there's 3 types of iron. The dinosaur type is the iron dextrin. The convenience is that it's very cheap and it saves money if that's an issue. But you have to do a hypersensitivity test. It needs to be either underneath the skin, like the same way they do a penicillin test. And sometimes the patients cannot get all the infusion in one single infusion. So it's a little more inconvenient for the patients. And there's 2 other types of iron. One is called the ferlicet, which is the ferrous gluconate. That's probably the most commonly used in the inpatient setting. And there's another one called venous sucrose ferrous Venofer. Venofer stands for, you guys can look it up on the it's
Iron sucrose.
yeah, very good. Yeah, so this needs to be done in an infusion clinic. It's costly. In the inpatient setting, we need to sometimes replete them. Like you're supposed to give 1 gram, like the loading dose. Most of these irons we give about 200 milligrams per dose per day. So it's 5 days of IV infusions. One of the contraindications is if you have a patient with an active infection, you're not supposed to be giving IV iron because you can make things worse. But generally speaking, most patients, they can tolerate the oral iron preparations. They're a lot cheaper. And one thing about oral iron that you guys should remember from now on is that the absorption is limited by the presence of food or other medicines. So when you advise your patients to take oral iron, they need to be taken on an empty stomach, which means 1 hour before eating or 2 hours after eating. Without any other medications. Like, for instance, like if you're taking Synthroid and iron, that's a bad combination because both of them will be affected. Both of the absorption will be affected. So, so there are a lot of like interactions, but iron usually we advise patients to take them on an empty stomach. Okay, so EPO. Just to give you guys like a little summary, EPO is responsible for at least 50% of the cost of end-stage kidney disease in the United States. This molecule was invented back in the 80s. Amgen went from being a garage company here in California to become like one of the top 10 Fortune 500 companies in the world. And back in the 80s, they were like pushing for indications. They were trying to look for every possible indication to get FDA approval for the management of anemia. So they were giving it to critically ill patients, they were giving it to chemotherapy patients, they were giving it to all sorts of settings of anemia settings. And then a lot of these practices changed when good quality studies started coming up. Most of them like in the late 1990s and the early 2000s, when we found out that a lot of EPO was detrimental. In fact, now we have very strict guidelines where EPO should be used, and no one should like actually try to do an off-label indication for using these medications. And one of the settings is definitely anemia of chronic kidney disease with a hemoglobin target between 10 to 12. So you do not want to exceed more than 12, because when we do that, we know that the risk of having a thrombotic event significantly increases, including a myocardial infarction, a stroke. So we have very strict protocols. If the anemia, if your hemoglobin is uptrending, then you hold it or you lower it by 50%. So they have all sorts of like sliding scales where like either nephrologists or renal pharmacists, they need to educate the patients about it. And then we do it because before EPO was invented, kidney disease patients were dying a lot of them were actually having complications related to transfusions. Like, it really transformed the way we practice nephrology, because in the 80s, kidney disease patients, they were getting transfusions almost on a weekly basis. And they were either developing like infectious diseases related to the transfusions, or they were developing iron overload, and EPO really made a difference. But nowadays, you have to guys remember that there are very few indications, and there are some contraindications that you need to know by heart. You guys know which contraindications for EPO? Do you guys remember? Who should not get EPO?
I'm going to assume it's someone who's hypercoagulable.
Yeah, like somebody, like let's say you have like a recent stroke, you don't give EPO. Somebody with uncontrolled hypertension, you don't give EPO, because one of the side effects is actually hypertension. So if systolic blood pressure is greater than 165, we usually avoid using it. So you're supposed to check blood pressure before you give it. And also, if you have an active malignancy, you do not give EPO, because it's a growth factor, and you can actually worsen an active malignancy. If you have a malignancy and you need to use this needs to be given by a hematologist, and not any hematologist, but you have to be registered at a national registry where they keep a database of patients with cancer that are actually receiving erythropoietin-stimulating agents. So as a nephrologist, whenever I get a case of a patient with an active malignancy, I defer the anemia management to the oncologist. We do treat patients with chronic kidney disease patients with anemia, because we know that hemoglobin less than 10 is associated with worsening LVH, and also with increased mortality. And we know that the sweet spot for these patients is anywhere from 10 to 12, and that's why we try to balance it out so the patients are actually meeting that target. So I was telling you guys that the cost, 50% of the cost was related to EPO. We're talking about a good $25 to $30 billion per year in the United States. So because of that, the Congress, they passed a law in 2009. It's called the Bundles of Care for End-Stage Kidney Disease. And I don't know if you heard on the news that DaVita was convicted for practices. They were actually like doing all sorts of like strange things with like giving patients a lot of EPO, or they were discarding the EPO instead of using it in other patients, and they were like billing a lot of like EPO to Medicare. So that's one of the reasons, because the cost was just completely out of control. So they passed this law in 2009, and now dialysis centers, they receive X amount of money to take care of that dialysis patient, and they won, and that includes only renal pertinent care, because before that, nephrologists were doing all sorts of things in the dialysis unit. They were doing diagnostic testing, they were doing transfusions, they were sending labs that were not renal pertinent. So now with this new law, they only get paid for renal pertinent things. And that's why if you guys rotate through a dialysis unit, if a patient is having symptoms, they don't do anything. They just call 911. Basically, if a patient is having chest pain, before we used to do EKGs and try to manage them, give them some oxygen. Right now, for liability reasons and obviously it changed the practice, because they're not getting compensated for any of these things. So now that we're doing that the Congress actually passed the law, for the first 5 years, the cost of ESA, erythropoietin-stimulating agents, is actually downtrending. Why? Because more and more literature is showing that giving IV iron to dialysis patient is actually as effective as giving EPO. And it's actually one of the perfect examples how legislation actually shifts the cost of like the way they were practicing nephrology. And that's one of the reasons, guys, when you're in practice, you're going to see a lot of patients on hemo and very few patients on peritoneal dialysis. Have you guys ever seen a patient on peritoneal dialysis, by the way? Yeah, okay, so they're not as common as hemo. So most of the patients are on hemo. And part of that is because of the compensations. And historically, the nephrologists were not very comfortable, or they didn't get enough training exposure in dealing with peritoneal dialysis patients. And more importantly, they had a conflict of interest. they own dialysis units. So if I own a dialysis unit, I'm less likely to recommend home dialysis to my patients. So now what they're doing is that Medicare is actually, there's like a penalty of like 3 months that you don't get paid if the patient goes into hemodialysis. Whereas if you go into peritoneal dialysis, they start getting paid from day one. So they're trying to do all sorts of things to start growing the population, the peritoneal dialysis population, because the U.S. is the only country in the world where there is a tremendous discrepancy between home dialysis and hemodialysis. We're actually like 90 and 10. Like most countries, most developing countries, actually peritoneal dialysis is the modality of choice for management of end-stage renal disease.
Peritoneal dialysis wasn't as effective.
Very effective.
Oh, it's
very effective. It actually has a mortality benefit in the first 2 years. Patients on peritoneal dialysis, they have an increased survival, and but that mortality benefit actually disappears after 2 years. And one of the nice things, I'm a big advocate of home dialysis because it's very beneficial as a society. It reduces costs significantly. If you think about it, if you go to a dialysis unit, you have a bunch of people taking care of you. If you do home dialysis, you just do it yourself. So that reduces the cost tremendously, number one. Number two, it empowers the patients to take control over their health, and we know that patients that are involved, they do better than patients that just go. If you ever go to a dialysis unit, you're going to see a lot of patients that are, they already gave up. They're just going there because somebody's picking them up and taking them to get the treatment, and they're really hopeless. Whereas the peritoneal dialysis patients, generally speaking, they have a higher functional status. And another thing that's important in peritoneal dialysis, if you guys remember, I think I told you about like GFR. If you have a GFR of 3, you still make urine. It's the last thing that disappears. And interestingly, when you start hemodialysis, like most patients on hemo, they don't urinate. If you go to a dialysis unit and you ask them, hey, you guys still make any urine? Most of them are going to say no. And that happens in a period of months or years, or that can happen actually fairly quickly. And that has to do with many reasons. One of them is, let's say if you have diabetic renal disease, the disease will continue to progress. Dialysis is not going to arrest the progression of the renal damage. But what happens is that uremia, it's a stimulus for osmotic. It's an osmotic diuretic when you have a high BUN. When we start the patients on hemo, you're removing that osmotic stimulus, so patients, the urine output goes down. And also, every time we remove the fluid with the machine, we're actually causing more damage to the kidneys, because there's a lot of like hemodynamic fluctuations in the hemodialysis patient. Versus peritoneal dialysis, the transport happens in a very slow fashion. Like patients are attached to the machine, like they connect themselves to the machine, and they get dialysis over 8 or 10 hours every evening. So they just basically, let's say 8 p.m., I just connect myself. I can still do my stuff, you don't have to go to sleep. But when you go to sleep, the machine is continuously removing solute and removing water. Versus hemo, anywhere from 3 to 4 hours, it happens very quickly. So hemodynamically is a lot more friendly to be on peritoneal dialysis versus hemodialysis. So there's a lot of misconceptions about PD, and like I was saying, like we got into this topic because I was just giving you an example in how like EPO historically did this, and now it's going down because legislation. Same thing in the United States. We're trying to move more and more patients to home dialysis, not necessarily peritoneal dialysis, but you can do home hemodialysis. Have you guys ever seen a patient on home hemodialysis? It's pretty cool. Actually, you have to have a treatment partner, and you do hemodialysis at home. And the treatment partner is responsible for cannulating. Although I have my patients, usually they self-cannulate, but there's got to be somebody around in case of some technical issue or like a blood spill or some sort of like emergency. You need to have somebody around. But like we're trying to move more and more patients. And I'm going to tell you, if I were a dialysis patient, the last thing I want to do is to go to a dialysis unit. I'm probably just gonna go ahead and just do dialysis myself. So I want you guys to know that, because you're gonna see patients telling you, oh, I'm doing home hemo. You're gonna be like, what is that? So you already know.
Vascular surgeons don't like to see their
Say it again.
The vascular surgeons don't like this either, right?
No,
They're losing business in that way.
Oh, I mean, no, they still have to have a vascular surgeon.
For peritoneal?
Or peritoneal. The vascular surgeons are the one putting the
Oh,
catheters.
they do?
Yeah,
Okay.
yeah. It depends on the medical center, but they can be either be placed by intervention radiologists. In my medical center, the vascular surgeons are the one doing the peritoneal dialysis catheter placement. Yeah, it's an OR under general anesthesia procedure. Yeah, it's pretty cool.
Is there like a downside to doing peritoneal? Like what's the...
Excellent question. So if we were to do a head-to-head comparison, so hemo, well, if you think about it, like things to have in mind, like hemo, you have a membrane, right? And you get rid of that membrane. Every time you give a treatment, you use the artificial kidney and you discard it. Some dialysis units recycle them and they use them in the same patient. That's not a recommended practice, but some places in the US they still do that. Whereas if you have a peritoneal dialysis patient, you have one membrane and you have to take care of it. And that membrane has very unique transport characteristics. In other words, your membrane is very different than my membrane. And based on understanding the transporting characteristics of that membrane, that's how I'm able to adjust the prescription, the peritoneal dialysis prescription. Some patients are rapid transporters, some patients are slow transporters, and that's what we have in account when we have a prescription. So having said that, the way peritoneal dialysis happens, there is always a risk of complications related to the membrane. One of them is peritonitis. Nowadays we have safer techniques. We have like a non-returning valves that decrease the risk of peritonitis. We also have cyclers. Like in developing countries, the patients usually do manual exchanges. Like in other words, there's no machine involved, and they just infuse the dialysate into the tummy. They wait for about 2 to 3 hours or 4 hours, depending on the dwell time that you prescribe, and they have to drain after 4 hours. So if you think about it, the connection and disconnection, that increases the risk of having peritonitis. Now in the US, most of my patients, I'm going to say all of my patients, they do a manual exchange during the day when they need to, but all of my patients are with the cycler. So the risk of peritonitis is very low. So, and even if they develop peritonitis, you can treat this as an outpatient. You do intraperitoneal antibiotics. You infuse the dialysate with antibiotics. So that's one difference. Hemo patients don't get peritonitis, but hemo patients can also get pretty nasty fistula infections. When you do a head-to-head comparison, the infectious complications are slightly higher in peritoneal dialysis compared to hemodialysis. But if you were to look at the other things, let's say you have a patient with like pretty bad heart, like somebody with like left ventricular ejection fraction of 20-25%. Those patients actually they have a very hard time on hemo. I explain you the reason. The fluid shifts happen in a very drastic fashion in hemodialysis, whereas the fluid shifts happen in a very slow fashion in the peritoneal dialysis patients. So those patients, for instance, they benefit from being on PD. So another metabolic consequence of doing PD, you guys know how it works, right? We give sugar. You know, this dialysis solution, they're dextrose based. So you give a lot of sugar, and when you infuse that sugar, technically I'm giving about 800 calories more per day. So you need to disclose that to the patients, because if they don't pay attention to their diets, or if they remain physically inactive, they're gonna gain weight. So that's another issue. There are 3 different types of solutions, and I don't know if you ever see a patient, they have like yellow, green, and red. The yellow is the lowest dextrose concentration. The green is intermediate. The red one has a lot of sugar. We only use the red one when we want to remove a lot of fluid, when we want to ultrafiltrate. Because if you have a higher dextrose in your tummy, that actually carries more, it's like a solute. It's like a concentration gradient. If I have a lot of sugar here, that's going to pull a lot of fluid. So we technically tell the patients, don't use the red unless you have to. And if you use the red, you need to let me know. But most patients are on the green or yellow. If they're very good with the fluid restriction, they can get away without using the yellow. especially I told you guys that patients on PD, they tend to maintain a urine output for much longer than patients on hemodialysis. And having a urine output is a blessing, not only for quality of life, because you guys know what is the fluid restriction for a dialysis patient. You need to know this, by the way. How much fluid can a dialysis patient drink in a 24-hour period? It's important that you guys know this. If you're admitting somebody with fluid overload, a dialysis patient, these are the questions you need to ask the patient when you're presenting to your attending.
I know how much we want to balance them. So like, is it 500 cc?
It's usually 1 liter. 1 liter, so 32 ounces. So, and this is important because if you're making no urine, the safest fluid removal that we can attain in a dialysis machine is no more than 4 liters. In 4 liters, it also depends on your body mass. If you're a small person, I'm going to try to remove 4 liters. That's dangerous. So there are other classifications that they actually advocate for, like 12 mLs per kilogram to be safe. But generally speaking, anywhere from 3 to 4 kilograms. So if you remember the way we do dialysis on Monday, Wednesdays, and Fridays, or we do dialysis on Tuesdays, Thursdays, or Saturdays, right? So there's always a period of 3 days. So if you are a compliant patient and you do only 1 liter, you're gonna gain 3 kilograms. So that's safe. Some patients are not compliant, or I'm gonna say some, like probably like 50% are not compliant, but that's the reason why they end up on dialysis, by the way. When I started doing nephrology, one of my internal medicine attendings told me like, oh, the dialysis units are full of crazy patients. Like, it's not the dialysis that makes you crazy, it's just like patients that are non-compliant, they're more likely to end up in that situation, like requiring dialysis treatments. But anyway, so generally speaking, if you're admitting someone to a hospital with CHF exacerbation, you need to ask how much fluid do you drink, or how many kilograms do you gain in between your treatments. They're not supposed to gain more than 3 kilograms. So if the patient is compliant. Okay, so that peritoneal dialysis patients, they tend to have less admissions for CHF, going back to your question. Why? Because they still have a urine output. And having a urine output, I was saying, is not necessarily associated with better quality of life, but also is associated with improved survival. And that's one of the reasons why we think peritoneal dialysis has a mortality benefit in the first 2 years compared to hemodialysis. So on your boards, I want you guys to remember that the best treatment, or the treatment that is associated with the best outcomes in end-stage kidney disease is preemptive transplant. Preemptive transplantation. So don't answer dialysis or hemo or peritoneal dialysis, or go on dialysis and then just do a transplant. It's preemptive, meaning that you bypass dialysis altogether. Right, you got it on your, there you go. So preemptive transplant. And you guys know what the wait time for a transplant in the US is?
10 years.
In California, 10 years, 8 to 10 years, it's a long time, right?